Good afternoon, and thanks for joining us for today's Healthline 3. I'm your host, Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, please make sure you're in a quiet room when you call, with your TV turned all the way down so that we can hear your question. That number to call is 318-219-4569. And today's topic is surgical interventions for fallopian tubes and ovaries. And joining me to talk about this is Dr. Karen Berkin. She's an OBGYN at Willis Knighton Women's Health Associates. That's in Bossier, right across the river. Thanks for joining us.
You're welcome. Glad to be here.
Absolutely. So we talked a little bit on our midday newscast about, there's lots of different things that you can expect as far as like a hysterectomy or a oophorectomy or a salpingectomy. How'd I do?
You did great. You got them all three.
So, kind of a big thing that we're going to be talking about is the distinguishment between them. Who's a good candidate for that, right?
Right. Yeah,
okay.
No, absolutely.
So maybe let's just dive in. Hysterectomy is probably the most common thing that people think of. So if you want to just kind of explain that, and we'll go from there.
Yeah. So a hysterectomy really just means removing the womb or the uterus, and the cervix comes with that. Now, there is a type of hysterectomy called a supracervical hysterectomy where you actually leave the cervix. There's different reasons why you may do that, and then just remove the uterus. But the tubes and the ovaries are not actually included in a hysterectomy. You have to specify if you want to take them or if you want to leave them. And a salpingectomy is removing one tube. A bilateral salpingectomy is removing both, because everyone has one uterus, one cervix, but two tubes and two ovaries.
Gotcha.
And so an oophorectomy is removing one ovary. A bilateral oophorectomy is removing both. Different reasons why someone might want to have a hysterectomy or pain, bleeding, fibroids, things like that. The ovaries really control your hormones. It's your brain and your ovaries that do the hormones. So your uterus, your tubes, your cervix actually do not make any hormones in and of themselves. So that's a little bit of a misconception sometimes. A lot of people avoid a hysterectomy or delay a hysterectomy even though they're having problems, because they think that if they have that surgery, their hormones are going to change, they're going to immediately go into menopause. But that's not true. It's very easy to actually leave the ovaries behind, one or both ovary behind, and just remove the uterus so that your period goes away, you no longer have the pain associated with your cycle, but you still have all of your hormones intact until on average age 50, 51.
Gotcha. Yeah, that's very interesting too, that your ovaries and your brain kind of control that. And you're talking specifically about female hormones when you talk about that. Okay.
Yeah.
Very interesting stuff. Okay. So why would someone want a salpingectomy or a bilateral salpingectomy where you're removing one or both tubes?
So in an emergent situation, if someone's pregnant, there can be a situation where the pregnancy ends up outside of the uterus, and the tube is the most common place that pregnancy would end up. That's called an ectopic pregnancy. That's a very life-threatening condition if that happens, and sometimes you have to remove one tube in an emergent setting because of that. Other more common reasons why people will have a tube, really both tubes removed, is if they're done with their childbearing years and they don't want to have any more kids. A bilateral salpingectomy or a tubal ligation are two different ways that you can basically provide lifelong contraception. There's lots of different ways to do a tubal. The old ways were really just removing a portion of the tube, whether it was the end or the middle, but there's a lot of new data out in recent years that shows just getting the whole tube out and not just removing a small portion of it, but removing the entire tube on both sides is actually beneficial from a long-term health standpoint.
Gotcha. Okay, and so from what I can remember from biology class, salpingectomy, you're basically taking it out of the body. So a tubal ligation, what is the difference between those two surgeries?
So tubal ligation, there's several different ways to do that, and that's colloquial what people will refer to as a tubal. I've had a tubal, and so the tubal ligation is where you remove a portion of the tube. You're basically cutting out the midsection of the tube. Now, there's other ways surgically that people can have their tubes tied. There's a way that you can put these rings called fallope rings. They look basically like rubber bands that you can put around the tube to prevent an egg from passing through and to prevent pregnancy. There's also these clips that you can apply, metal clips. They're called Filshie clips that you can place over the length of the tube, and that will block the tube essentially and prevent pregnancy. Those ways are falling a little bit out of favor just because now some of the newer data out that just shows it's better overall from a cancer standpoint to have the whole tube removed on both sides.
Gotcha. Yeah, okay. And so for when you're removing the ovaries, like when would you maybe recommend someone to remove their ovaries?
So the average age of menopause is around 50 to 51 in the United States. Now, anytime after 40 is considered normal, so sometimes people can go through menopause earlier, or even 55, 58, that's not uncommon. So when someone has a known genetic condition that predisposes them to breast cancer, colon cancer, pancreatic, ovarian cancers, uterine cancers, those cancers are often linked to one another by certain genes. The younger someone is diagnosed with a cancer, the younger the family member that has been diagnosed with the cancer is, the more likely there's to be a genetic component there. And so fortunately now there's genetic tests available, easy blood tests that are often covered by insurance, that you can have your own self tested for a wide range of these genes that we now know of. And if someone is positive for one of those genes, depending on which one, their lifetime risk of ovarian cancer may be, instead of 1 to 2% like the general population, it might be all the way up to anywhere from about 20 to 40%. And so in that instance, that person might decide that I want to go ahead and get my ovaries out. Timing really depends on how early some of their other family members were diagnosed with cancer, and then also if they're done having kids. Typically we don't recommend taking out someone's ovaries before about age 40 to 45, even in that setting. But as soon as somebody's done having kids, if they're a very high-risk patient, they can have what's called a risk-reducing bilateral salpingo-oophorectomy, which is, I know, again, another mouthful, but that's where you go in and surgically remove both tubes and both ovaries to significantly reduce their lifetime risk of cancer.
Yeah, and ovarian cancer is maybe one of those risk factors, and you said uterine cancer as well. So that's important, and especially like you said, if you have a family history, just that peace of mind
absolutely
is worth its weight in gold.
Yeah. Ovarian cancer, it's one of those cancers that is not typically more aggressive than any other type of cancer, but it is found later because the organs are on the inside. It's not that you see a spot show up on your skin or have, a symptom that's very obvious. A lot of times the symptoms are vague: pelvic pain, maybe some bloating, a little bit of discomfort or bowel changes, but who doesn't have those, from time to time? And so the big deal with ovarian cancer is how late it's typically diagnosed. There's no great screening tool for it yet.
Gotcha. Yeah. Okay. Well, if you're just joining us and you have a question for Dr. Berkin, she's an OBGYN at Willis Knighton Women's Health Associates in Bossier, and just give us a call at 318-219-4569 so that we can answer your question live in the studio. So, one thing that we talked about is the difference between the hysterectomies, salpingectomy, oophorectomy, but I think you said maybe when we were off air, misconception is that hysterectomy is going to, change their hormones, but that's not necessarily true.
Correct. Removing just your uterus is just removing the bleeding. Your uterus's sole goal is every single month it is trying to get pregnant. And that's from an evolutionary standpoint. And when it doesn't get pregnant, then the next month it hits the reset button and it tries again. The brain sends signals to the ovaries make hormones, and that is what dictates your menstrual cycle. And really feeling hot flashes and night sweats and mood swings and all the typical menopausal symptoms, those are due to the dropping off of your estrogen levels, which comes with menopause. Now your periods also stop as a result of that, but just your actual hormone production is really due to the ovaries, and so you can remove the uterus and your hormones stay the same. And in that instance, your indication later in life that you're going through menopause would be hot flashes and night sweats and mood swings, because you don't necessarily have a menstrual cycle to go off of anymore.
Yeah, right. And so if, let's say, for example, someone removed their ovaries at a much younger age, like in their 30s or something, will that put them in menopause?
It will, and it does put them at increased risk for other things. Bone loss, estrogen protects us against bone loss that we see, osteoporosis later in life. It also protects our hearts, and so there are a lot of advantages to keeping your hormones as long as possible. Now, for someone that needs to have them removed for a cancer risk or any other reason early, you can replace some of those hormones that they've lost with medication, but it isn't quite the same. You know, we can get close with hormone replacement, but you can't quite match what the ovaries can do on their own. So anyone that does have their ovaries removed early, they are predisposed to heart disease a little bit earlier, bone loss a little bit earlier, but sometimes the risk of cancer very much, it outweighs the risks.
Yeah, right. And speaking of risks, what are some risks factors of either removing your tubes, removing your ovaries, or removing your uterus, all the things, all the surgical interventions? Surgery is not necessarily without risk. So what would you say are the big risk factors for this?
So anytime you have surgery in your abdomen, typically when we do an oophorectomy or a salpingectomy or even a hysterectomy, we're trying to do them in a minimally invasive fashion. So, you're going laparoscopically through small incisions. We have the ability to do robotic surgery as well. So you have even tinier, finer, more meticulous, instruments, to where you can do really fine dissection. So the risks have become very low, and the recoveries become really good because of that. But there are surrounding structures. You have your ureters, which run from your kidneys to your bladder. You have your bladder, and your bowel is there as well. So you do have to be careful not to injure any of those other structures, nerves, blood vessels. But outside of that, I don't think I've ever had anybody tell me that they regretted having a hysterectomy or having different parts removed, because for the most part they've been struggling for a while and they've had symptoms or had pain for a long time, and finally they kind of cross over and are pushed to the point where they've tried everything, and so they decide to have surgery, and then they come back to their post-operative visits and whatnot saying, I should have done this 5 years ago.
Yeah, that's awesome. So, we talked about removing all of these things for maybe a cancer risk. Now, what about, you mentioned pain, those symptoms of maybe pain or feeling uncomfortable. What are those other symptoms that someone should look out for and then maybe consider these surgeries?
So, because the ovaries are basically stem cells, they have the genetic information to become, half of a human being. And so those cells can transform into really any, different body tissue. And so you can get some cysts on the ovary, you can get different tumors and growths and things like that. So, not only would you necessarily remove, a tube for contraceptive benefit, but a lot of times people have an enlarged ovary, a cyst on their ovary, or a tumor, a solid tumor that they need to have removed from a pain standpoint, bloating, change in bowel habits. A lot of times people deal with constipation. Even anyone that's had a prior infection in their abdomen or certain, STDs, those can cause what's called pelvic adhesions. And so things that are supposed to be free floating and able to kind of move around a little bit become pretty tethered to the sides of the abdomen and whatnot. So a lot of pulling, tugging sensation, discomfort with intercourse. There can be all sorts of reasons, physical activity, working out.
So definitely, if it feels off, then talk with your OBGYN and definitely consider the options moving forward. So what is the recovery like after having a surgery like this? I don't know if it's different for each type or?
So for having your ovary or both ovaries removed or your tubes removed, it's very quick. It's an outpatient procedure typically, unless there's some extenuating circumstance. Sometimes we see ovaries get very large, and so those sometimes might be bigger, more involved surgeries. But for a typical oophorectomy or salpingectomy, it's done laparoscopically. It's typically an outpatient procedure, so you would come in that morning, have it done, be able to go home the same day after the surgery. As long as you weren't doing anything very strenuous for the next week or so, most people go back to work. If they work at a desk or don't lift anything heavy, most people can go back to work at about a week, 2 weeks max. If it's a bigger surgery that requires more of a large open incision, then sometimes it's upwards of about 6 weeks before you can get back to your normal routine. But there's very small incisions, no bathing restrictions really. You can eat whatever you want. So the recovery has gotten significantly better over the years thanks to laparoscopic surgery.
Yeah, for sure. And I think that's across the board in any kind of surgical intervention. So what about, let's say someone did not want to have a hysterectomy or to remove anything. What are maybe other things that you can do? I know like ablation is one of them. I don't know if you can speak to that or if that's what you regularly do at all.
So there's something called an endometrial ablation or a uterine ablation, which is where there's multiple types that you can use, multiple devices, but in general, you're using some type of heat to burn the lining of the uterus and essentially kill it to where it does not bleed and it doesn't proliferate. So the goal there would be to stop a period. Those work very well for a lot of patients. The younger someone has an ablation though, the more likely that lining is to eventually grow back over time, because if someone has an ablation when they're 30, they may have 15, 20 years left before, even 25 years left before they go through menopause, and that's a long time and a lot of hormones, and sometimes that lining does grow back.
Yeah.
But there's other surgical procedures as well. If someone has polyps or fibroids or something in their uterus, you can go in and do what's called a myomectomy, which is where you remove a fibroid but preserve the uterus so that they can have babies in the future. You can also go in with a camera that you look into their uterus with, and we have a device that can remove and shave down and sample the lining or remove a polyp or a fibroid that way. That's called a hysteroscopy when you do that.
Very cool. Yeah, and it just really reiterates that it's all an individualized thing. It's what one person needs is not what the next person needs or wants. So we have Amy on the line. Amy, thanks for joining us, and what's your question?
Yes, I've been having hot flashes since I was probably about 46. And I'm now 59, and I'm still having them. And I just wish I knew something that could control them. My mama had them, and she was on a drug called Premarin. It's like a hormone replacement therapy. I'm just wondering if maybe I should consider that.
So with menopause, true menopause, when someone's considered postmenopausal, it's when you have gone a full year without a period in the setting of that time in your life when your estrogen levels have dropped off. Now, there's something called perimenopause, which is when you have not completed your period, you haven't been considered postmenopausal, your period hasn't stopped, but your hormones do change. We know that our hormone levels are not in your 40s what they were when you were in your 20s. And so pretty much the average timing of things is several years before someone actually goes through menopause. They will enter this perimenopausal state where your hormones are declining and those other symptoms, hot flashes, night sweats, vaginal dryness, mood swings, sometimes hair, skin, nail changes, libido changes, all of that can happen prematurely before that period actually fully stops for a solid year. And so hormone replacement is a great option. Now, it doesn't come without risks. There's certain patients that are great candidates for it, and there's other patients that aren't, and that's a conversation to have, with your doctor. But hormone replacement is an excellent way to kind of mediate some of those symptoms, and it depends on what your symptoms are and how many of your female parts you still have, and that determines what type of hormone replacement we do. We know that if someone still has their uterus, we have to not only replace the estrogen, which is what you're missing, we also have to replace progesterone, because that is the balancing hormone. And if we give someone estrogen without supplementing that progesterone, then eventually a period will come back, that lining will regrow. It's a potential risk for uterine cancer, and so you need the balance of the two. So the only time somebody should be only on the estrogen is if their uterus has already been removed.
Good advice.
There are other different things too for the patients that are not great candidates for hormone replacement therapy. There's newer medications coming down the pipeline all the time that help with specific aspects of menopause. So if hot flashes is your biggest issue, there's medications just for that. If it's mood swings, we can focus on that. If it's libido, there's something, different options. When someone has the full gamut of symptoms and it's just too many medications to put someone on something for each ailment, then that's when hormone replacement therapy really helps, because you can target all of them with just one treatment.
Gotcha.
Okay.
Oh, thank you, Amy, for joining us.
Yes. Thank you so much. I saw the doctor on the channel, and I said, "Oh, let me call," because this has been a question that's been burning, in my mind for a long time. And I said, finally, I get the chance to talk to the doctor.
Yeah. Well, thank you for calling.
Absolutely. And if you're just
joining,
joining,
y'all have a great.
Go ahead.
Go ahead. No, go ahead.
Oh, that was it. Thanks for joining us.
Okay.
And if you're just joining us and you have a question for our doctor, just give us a call at 318-219-4569, and we're going to answer it right here on air. So another question that I have is, so what would someone, or why would someone choose ovarian conservation versus removing them?
So I always have this conversation with patients when I'm sitting down with them and they're coming in wanting a hysterectomy, or maybe they need a hysterectomy, because it's a big deal, whether somebody keeps their hormones or loses their hormones. And so I talk about all those risks that we mentioned earlier of bone loss and heart disease and the menopausal symptoms that come along with having your ovaries removed. But we also talk about the risks of keeping them, ovarian cancer. Even if ovarian cancer doesn't develop, there's other benign conditions of the ovaries and the tubes where if someone does keep them and has a hysterectomy, studies show there's about a 10% rate of reoperation. So someone having to go back to the operating room later after a hysterectomy just because of an issue with the ovaries. It's pretty standard now that most people, when you do a hysterectomy, they also will remove your tubes because they serve no purpose after the uterus is gone. But I certainly sit down and have that conversation with patients, and if they have a strong family history of uterine cancer, ovarian cancer, anything like that, we can even do the genetic testing before we do the surgery so that we know what their genetic risk is. Sometimes if they're on that cusp, maybe they're 44 years old or 45 and they're trying to decide, is it worth it to keep my hormones for another 5 years or so? Or since I'm going forward and having surgery, should I just get them out now? And there's some lab tests that we can do that can show potentially if that person is close or nearing menopause. And so we can kind of guide them a little bit. Also, if their mom and sisters and aunts had gone through menopause at a particular age, they're more likely to go through that at a particular age as well. So we can kind of help guide them. And a lot of people come in knowing, I want to keep my ovaries, I want to keep as much of them as looks, normal. And then other people come in and they say, I'm having surgery, I don't want to have this again. Just take it all out, no matter what. But there's lots of things that we can do to help guide the patient with labs and different genetic tests as well.
Gotcha. So what are the typical lab values that you're looking at to determine this?
So there's one of the key ones is an estrogen level, which is estradiol, to see if that number is declining outside of the normal range. And then there's also a hormone called FSH. It stands for follicle stimulating hormone. That's one of those hormones that comes from your brain. I mentioned the brain earlier as part of the control system for your hormones. And follicle stimulating hormone comes from your brain, and it's a signal to your ovaries to make estrogen, essentially. And so even before someone's estrogen levels drop down, oftentimes the brain is sensing a shift, and so it will actually make more FSH to try to tell the ovaries to make more estrogen. And so we see a rise in FSH and a decrease in the estrogen when someone's nearing menopause.
Very interesting. Okay. And I think the hormones are just so interesting as well. And so you also offer the hormone replacement therapy. So take me through that process. What would we could, use like a fake patient if you want to, paint a picture or whatever. But tell me like that process when you would decide someone needs that.
So if someone is very young when they're having a hysterectomy, that's kind of always a conversation that we have and that I bring up, even if it's not something that they're thinking about. I always talk to them about potentially replacing some of their hormones that they're going to be losing. But in someone that's kind of on the border between about 45 and 55, which is honestly when most hysterectomies happen, I sit down and I talk to them basically about different things that those hormones provide for them, different risks that are associated with losing the hormones or keeping their hormones. And it's very important to know what that patient is wanting, because everybody is different. Some people have fears or misconceptions about having their hormones removed, and so you have to kind of debunk some of those a little bit. But if someone decides that they want to go ahead and replace hormones, you need to make sure that they're a great candidate. They can't have a personal history of breast cancer, for example. If they have their uterus still, then you have to talk to them about dual hormone replacement therapy, so replacing progesterone and estrogen. If someone has very uncontrolled high blood pressure, uncontrolled diabetes, has ever had a blood clot or a stroke or anything, then estrogen will make them more likely to have those blood clots form again or to have a stroke. And so you have to tell those patients, even though this would really help you, some of the negative risks associated with it are too great. Right. And so then we have to shift and look at other options. But there's pill forms, there's patches, there's some injectable forms, there's some compounded medications.
And is there creams?
There is creams. Okay. The patient that called earlier, she was talking about something called Premarin. That comes in, that's an estrogen replacement. It comes in a pill form. It also comes in a vaginal cream. Gotcha. Because sometimes people just have vaginal dryness, pain with intercourse, and they don't need full systemic body hormone replacement. They just need some place right on the source. And so that's when creams or vaginal inserts can be helpful.
Gotcha. Awesome. Okay, so you are right across the river in Bossier City. So tell me, are any of your services, whether this is surgical or just coming in for a visit, is it covered by insurance? Most insurances that you accept? Most
insurances cover this very well. Now, we always, before doing any surgical procedure, we always run the numbers. We submit what we're planning to do and why as proof to the insurance, and they come back with us with a pre-certification and a quote, essentially, so that we know and the patient knows going into it how much out of pocket they'll be responsible for. Awesome. Yeah. Okay. And so tell us where you're located, maybe if you know the address. Yeah. So I'm at Women's Health Associates, which is at Willis Knighton, Bossier. It's 2400 Hospital Drive, Suite 240. So it's pretty easy to remember, 2400 Suite 240. It's right off 220. Yes, right off 220. So you can see it, right when you're passing the interstate. There's several buildings right over there, and so some people get confused, but my office is in the main hospital structure. Gotcha. It's just off to one of the sides. Gotcha. And then the number to call is 318-212-7931. And you're accepting new clients right now? Yes, I am. Awesome. Do you have a website that people could look at too? Yes, if you just Google OBGYNs in Bossier or Women's Health Associates, which is the name of our practice, then you'll be able to look us up, find our number, see what we treat. There's little instructional videos on there and bios and everything.
Well, thank you, Dr. Berkin. It was so nice talking with you. And thanks for joining us. That's all the time that we have for today's Healthline 3.